Good afternoon, respected teachers, judges, and my colleagues. Today I'll be presenting a study about the refractive outcomes in high myopes comparing Barrett Universal to SRKT and Mancock adjusted SRKT. We aim to study the refractive outcomes in high myopic patients with axial length greater than 27 mm undergoing phacoemulsification using Barrett Universal to SRKT and Mancock adjusted SRKT. Cataract surgery in high myopes can be challenging because of the postoperative refractive surprises and patient dissatisfaction. The older generation formulas can lead to refractive surprises when used in high myopes. The newer generation formulas like Barrett Universal 2 can give satisfactory results after cataract surgery in these patients, but it could be used only in advanced machines like IOL Master, Argos, etc. This is a single-center retrospective study. EMR of the patients with axial length more than 27 mm and with a minimum postoperative follow-up of 3 months was evaluated. We evaluated the preoperative best-corrected visual acuity, preoperative spherical equivalent, anterior segment and posterior segment findings, and postoperative refraction. A-scan biometry was done using IOL Master 700. Those patients with media opacity, axial length was calculated with immersion biometry. IOL power calculated with Barrett Universal 2 were implanted in all eyes. Biometry was repeated with SRKT using actual axial length and Mancock adjusted axial length. The optimized axial length equal to 0.8453 into measured axial length plus 4.0773, and we found out the residual refraction. We excluded those patients who underwent SICS, post-refractive procedures like LASIK, secondary IOL implantation, patients who were left aphakic, and those who had ocular conditions affecting visual acuity other than high myopia, and those cases with intraoperative complications. Coming to the results, the mean age was 53.2 plus or minus 12.2 years. There were 48 males and 52 females. The mean axial length was 29.37 plus or minus 1.89 millimeter. Mean ACD was 3.47 plus or minus 0.39 millimeter. 83 eyes was implanted with plus powered IOLs and 17 with minus powered IOLs. This is a table comparing the variables in accordance with the axial length. Most of the patients were, so for the ease of comparison, we divided the data into two groups. That is the eyes with 27 to 30 millimeter and eyes with more than 30 millimeter. Most of the patients in 27 to 30 millimeter axial length group. When comparing the both groups, in more than 30 millimeter axial length group, the mean age of the patients was less. That is 48 compared to the 55 in other group. Not much significance were noted in, difference were noted in K reading and ACD between the two groups. The mean preoperative best corrected visual acuity was logmar 0.78 and mean postoperative best corrected visual acuity was logmar 0.2. This shows a significant improvement in the visual acuity post cataract surgery in this high myopic patients. The IOL power implanted in the 27 to 30 millimeter axial length group was 6 diopters, and in the more than 30 millimeter axial length group it was minus 0.4 diopters. This is another table showing the residual refraction in the plus powered IOLs. Here we can see that the Barrett Universal 2 and SRKT with Mancock adjusted axial length gave almost similar results. But when it is used with normal axial length, SRKT used with normal axial length gave hyperopic surprises. In minus powered IOLs, SRKT when used with normal axial length, the hyperopic surprises were exaggerated. But Barrett 2 and SRKT with Mancock adjusted axial length gave almost similar results. The mean residual refraction with Barrett was minus 0.25. With SRKT with normal axial length was plus 0.65. And with Mancock adjusted axial length it was minus 0.16. This is a stacked histogram showing the residual refraction by 3 methods. These are some studies which gave similar results. A study by Sang et al. That is the effect of axial length adjustment methods on intraocular lens power calculation in high myopic eyes shows axial length adjustment with SRKT gave similar results compared to the latest 4th generation formulas. And another study by Fouch-Rabi et al. Mancock adjusted axial length in SRKT formula for ocular biometry in high myopia showed that SRKT with Mancock adjustment is a reliable alternative to the more sophisticated formulas such as Barrett Universal 2, and this holds especially for axial length more than 27 millimeter eyes. So concluding, SRKT with Mancock adjusted axial length can provide satisfactory results in high myopia as compared to Barrett Universal 2. Since the newer generation formulas can be used in advanced machines, those peripheral centers where these expensive machines are not available, SRKT with Mancock adjustment can be used as an alternative in these cases. we had our limitations. We had only 15 eyes with postoperative uncorrected visual acuity of logMA 0. 30 eyes improved to logMA 0 with correction. So we couldn't use the postoperative refraction for comparing the performance of two IOL formulas in this study. We also did a logistic regression analysis to find out the factors which significantly affect the postoperative vision in the study, and we found that axial leg, choroidal neovascular membrane, and myopic macular degeneration with posterior staphylomas was related to the low postoperative visual acuity. These are my references. Thank you.
Nice paper, Dr. Aparna. But one of the conclusion which you derived was that Bangkok adjusted axial length proves to be a cheaper alternative to Barrett Universal 2, which is available only in IOL Master 700. I disagree because Barrett Universal 2 is free online formula. You can just go on the online feed anterior chamber depth, axial length, keratometry reading, and lens thickness is an optional factor. You can have it. Whereas Bangkok adjustment means you have to note down the axial length, then go on to the online calculator, multiply it, add some factors, and when you are getting similar results, then why do all those headache? And whereas in Barrett, you just feed, click, and you get, even on your phone, you can have Barrett Universal 2. And the latest formulas which are giving good results with minimal absolute error in axial length more than 27 millimeter are Barrett Universal 2, Kane, VRF. The Bangkok adjusted is now way behind if you see all the meta-analysis which have been published in last 3 years. So there is this is where I disagree. Otherwise, it's a very, very nice study.